Good afternoon, everyone. Thank you for joining us. This is the Integrated Healthcare Discussion Policy Development Session. We had a couple of sessions, which I'm sure most of you were at, where we touched on a lot of different things that sort of fed in and led into what we're hoping to cover here. This is a panel that I think is critical to CP's own policy development. I think we're looking for a way to move forward, and I think some of the discussion today will help us think about how we're going to actually move forward, where we're going to land on this whole piece. As I said earlier, I know that we're in different places across the association, but I think it's time for us to figure out where we can agree and how to move things forward on this topic. So today I've got a couple housekeeping things. I haven't gotten yelled at. I'm getting yelled at about a couple things that I didn't do. I need to let people know that there are CEU signups in the back. If you need CEUs, you've got to sign up in the back of the room, and then you also were supposed to have registered at the front desk when you came in. Okay. And I don't have any other housekeeping. I think that's it. If I screwed up again on housekeeping, I'm sorry. So let's move on. So for today's session, I'm very happy to have with us folks representing the groups, I think, that are sort of leading the way right now in the managed care / integrated care. And let's not call it managed care. Let's agree with that. It's not necessarily that. But what it will be is, I think, something that will offer an opportunity for thinking about funding in different ways. So with us today are Nick Capoletti from Triad, the center, Dr. Mark Levy from Empire Blue Cross Blue Shield, and then Ed Matthews, who is with ADAPT, but also has an intimate knowledge of what's happening on the PHP front. And we've asked them to share some of their thoughts about integrated care. And we thought we would start with, I think, it's sort of a definitional component, I think is the way we described it, so that we're all using the same terms and we understand what it is exactly we're talking about. And we think, or I think anyway, a lot of the hesitancy and confusion is because we aren't necessarily always clear on what exactly are we talking about when we talk about integrated care. What is it we mean when we say provider-led? What is it when we say fee-for-service? What are these things going to, how are they going to change? And people think they know, but I think if we just start with the same place, it'd be good. So I'm going to stop talking and turn it over to, I think, Nick, you were going to start, right?
Okay, yeah, thanks. Good afternoon, everyone. So when I think about integrated care, I have to first use my parent lens. And, we have a son, 33, with complex medical behavioral health, receives services in the system. And 10 years ago, when the subject first came up about managed care, I remember some of the Medicaid redesign work. I had a pit in my stomach because I had this vision of what managed care was. And through the last several years, I've been able to develop a much broader understanding that we're not talking about just an insurance product. We are talking about creating a different vision for the system of holistic care. And I think when we saw the panel earlier today, we saw elements of that, right? Where we can actually look at a person's healthcare needs, look at a person's long-term support needs, and be able to actually create a model of care through the mechanism of managed care to improve the quality of health outcomes for people, to close some of the disparities and the gaps that exist, to provide access to care, and then also how do we create and innovate long-term support services that will actually support people living inclusive lives in our community. So I think integrated care is all about looking at the person and being able to have the flexibility and the freedom working together with providers to actually support that individual.
I think what I'd like to add, Nick, is one of the things that we're talking about that's so critical in our ideas, this model that we would like to go forward, is that it's provider-led managed care. And I'm here as the CEO of Blue Cross Blue Shield, also as a physician and a geriatrician. And one of the things I appreciate so much is how much I learned from you and from the other providers in the room about what it is that you do, what the services are, what the challenges are, what the needs are for integration. And being provider-led allows that to happen, allows the system to be created through that lens. And so what then does managed care bring to that? What does coordinated care have to do that with that? And I think in the interest of sort of, setting out some ideas for our discussion, managed care really starts with care management and population health. And so one of the sort of phrases that we use is the right care, the right place, the right time. And one of the things that I've heard very clearly from all of you today is the emergency room is almost never the right place. And so how do we create systems of care together? How can we leverage the tools of managed care so that that care can be provided more readily where someone lives, whether that be in a home, whether that be in a group home, whether that be in an institution. So I think about care management is understanding the individual, understanding the populations that we serve. And again, when I think about the populations you serve, I hear a lot about people with extensive physical disabilities, and I hear a lot about people who have comorbid psychiatric conditions and behavioral challenges. And we're dealing with different populations of individuals in this care environment. How do we understand those populations, their individual needs, those population needs, and build systems to support those needs? And I think about the tools of managed care, and part of that is ensuring that there's network access, right? And it's not a panacea. We all know there are deep shortages of some provider types, but through our contracting, through being related to our commercial insurance partners, we can leverage the strength of larger managed care organizations with key providers to make sure that we build systems that provide adequate access. And the other thing that I would say that I think of as a core capability of managed care, we've got care management, understanding populations and the data, providing network access. And I've heard a lot about this over the course of the day today is payment innovation.
Right.
And how can we leverage the experience of managed care and mistakes and successes in payment innovation? How can we work together to identify those areas that we want to innovate together without leaving anybody behind, right? We're talking about long processes and how do we build the capabilities together to do payment innovation. So just probably more than you want to hear from me as a get-go, but I think, really exciting to think about what provider-led, coordinated or managed care can be.
So I think, Nick, you've got a way of describing some of the key choices for folks in terms of when we think about, what's in, what's out, the insurance. I think that's helpful for folks to at least contemplate. So if you could talk about that a little bit, that would be great.
So as we look at integrated care, one of the key things is ensuring that we are breaking down those silos that were discussed earlier. And if you think about it, we tend to slice and dice people based on labels, based on, we talk about person-centered care, but a lot of our actions are driven by the Medicaid billing code, the Medicaid description of the service. We have people who are Medicaid, we have people in Medicare, we have people who are, IDD, we have people who are IDD lookalikes. And I hear these different phrases, and at the end of the day, we have to look at all of the services and be able to integrate that in a comprehensive way to meet the needs of the individual. Individuals, I'll never forget a session I was in many years ago, and many of you may know Michael Kennedy, who's a phenomenal advocate and was a class member of Willowbrook. And he said to the audience, he said, if you're going to label me as Michael Kennedy. We have to start looking at the person as a unique individual. What supports do they need? Being able to empower the care managers to be able to develop a comprehensive life plan. But right now, we've come a little bit short from the standpoint of doing that with care management, in that we haven't empowered them. As I've listened to some of the 507 forums, I've listened to the Guidehouse forums, we have many people are coming forward and saying, I just want to be able to live independently, or I want a solution for my child. And I was saying this to Commissioner earlier, that we have examples of where we've solved just about every problem there is. The problem is we have to jump through all these hoops, and we've never developed scalable, replicable models of care that address the common needs of this population and integrate their behavioral health needs, their medical needs, the technology, as well as the long-term supports. And we have an opportunity here where we could potentially wrap these different systems together, break down those silos, and be able to deliver a service to the whole person.
And I think one of the things that comes up when you talk about the what's in and what's out is we have the HSBC waiver, but the 1115 waiver as well is an option. And where does this land? I think we don't have to solve that today, but to be thinking along those lines of what does each of those waiver opportunities allow us to do, what can be included in it, I think is a question for us as we move forward. So we have to think about that. And we've heard, the fear always, well, there's no savings in residential programs, but if we're talking about a whole person, what do we do? So which way do we need to go? And thinking about it that way.
Mike, one of the things that we hear repeatedly, and I know many of you as providers have experienced, is when somebody has a medical crisis, when somebody has a behavioral health issue or a dental health issue, and that is unchecked. What ends up happening is their level of acuity increases, the amount of supports they need increases, and they end up costing the system a lot more. We're seeing people rotated in and out of emergency rooms, going into the hospital for long-term stays. If we can look at the person holistically, if we can identify these issues early on, if we can create standards of care that we implement specifically for IDD, we're spending $11.5 billion on people with IDD in New York State. They deserve better than what they're getting. We can develop more specific IDD, Mark talks about population health, standards of care. We can inform those providers who are willing to step up and serve the population that we support in a better way. We can work with hospitals in a coordinated way, and we can keep people out of crisis, which ultimately means they'll need less services. We can keep them in their settings. We don't have to worry about them all of a sudden coming out of their setting and no place to go. We can support people living in the community longer. Families like mine, we want to support my son in the community. But we need to, every time we have a change of provider, I get a pit in my stomach because it's like, okay, am I going to be able to find another provider? Is that provider going to know anything about my son? Am I going to have to give him a lesson in his disability and his genetic syndrome? Our people deserve better than that. And we're spending enough that we can do it in a much more intelligent way, using population health, using some of the lessons, developing standards of care to improve the level, the quality of life of people.
I think one of the things that I think of when you think about what's in and what's out and what the opportunity is here, today there's, you as providers by the waiver services for the IDD population, you have residential services, you have employment and community support services, but it's separated from healthcare services, right? It's totally separate. So those can come together. You mentioned the 1115 waiver that the Medicaid team is putting together. That brings in community support services, so things like transportation, things like better additional employment assistance and opportunities. And so additional ways to integrate into and leverage other community-based organizations that provide services to the Medicaid community to bring all of those together to that whole person care plan that you speak about. So again, individualized, but now there's a much larger sort of menu of options that can be coordinated through data, right? So information becomes centralized. A single care manager has information about all of these different areas that can be brought together in synergistic ways. So I think, what's in the possibility here is really to coordinate through a provider and individual-led and conceived system, a way to bring all of these available services together in one place.
And Amir mentioned a couple things today, this morning, that I thought were really interesting and helpful. I mean, you talked about the 40,000 people with IDD that currently are in managed care, and I think in and out, we want that in, right? So what is it about
They're in for their healthcare, Mike, they're not in.
Right, exactly. They're in for that. So and that leads me to where I was going with this is, you know, if you think about what we're considering here, what is it we need to be thinking about being in? What are your thoughts about, you know, how we would possibly get rid of some of the silos, allow for the innovation, do the things that I think Amir did a good job of outlining are real opportunities here. So I don't know, Ed, you want to talk about that a little bit? What do you think the opportunities here?
Yeah, look. Okay. I worked, here's the way I look at this, all right? It's not necessarily from that level. It's, when I entered this field, I worked in the first group home created in the city of New York. Not old. So is it. So it went from a hostel to a community residence to an ICF to an IRA. We went from day services and pre-vote to day treatment to day care. We haven't changed much, folks. We really haven't, not at the core. We're doing what we were doing 50 years ago. We went from, you know, and, you know, look, I mean, it wasn't, when I went to work for what is now OPWDD, it was all state money. I mean, we had empty Willowbrook, and then they decided all 20 DCs had empty, so they had to do something, so they piggybacked on the nursing home regulations. That's how you got all of these federal money in. But not that much has changed. It's changed on the margins. It's changed, you know, people have a little bit more flexibility, but not everybody. So when Partners Health Plan was created in about 2015, and then, you know, realized the following year, thank you to Commissioner Courtney Burke, who basically just said me too on top of these fighters that were being created throughout the country. None of them were for DD. So, and look, I mean, it's a demonstration. And what it's demonstrated is that integrated healthcare, Mark, it hasn't demonstrated much else because, you know, it's still paying the fee-for-service on the long-term care side. So when you're talking about integration, you're talking about integrating the health and the long-term care side. And to me, that's the next step in providing better service. It doesn't matter what you call it. You have to integrate. You have to integrate the programmatic side, and you have to integrate the payment side. You know, it doesn't look. We spent the morning talking about the main pressures on the system, and commissioners here, and you won't disagree with this. You have two main pressures on the system. One is the special needs, the high needs population, and the other one is some failing providers out there. Those are the two biggest things that the department is concerned about. And that's not, you know, that's public knowledge. There's nothing new about that. An integrated system starts to bring those issues in a place where you can start to deal with them. You cannot deal with them in a non-integrated fee-for-service system. So there's two things, and this is the most controversial part for all of us. There is a main big difference that we all have to think about. It is the difference between system sustainability and provider sustainability. They're not the same thing. So in a provider-led care, providers have to figure out where they're going to fit in that, how we're going to fit in that, and how some will fit in it together in ways to be able to produce data, to do things, and to meet the needs of the population through something called IPAs or other things. I'm not going to get into all of that language today, but you've all heard this stuff. Is it a panacea? No. No. We're not talking about it solves every problem. If we started it tomorrow, there'd be fits and starts and mistakes and things. But but we keep moving forward. And one of the silos that they talk about is very simple. A residential program is no longer a program. It's simply someplace someone lives. It's somewhere where someone goes during the daytime. It's all integrated in a way. It's a fluid system now. It's not payment and that payment and the other thing. It's how their life is. And that's the only thing that makes any sense. Now, PHP hasn't been able to do that because, it wasn't created with a PM system that brought in the long-term care side. But 11.2 billion on the HCBS side. Let's throw in a couple more billion on the healthcare side. Let's throw in a couple more billion on the long-term care side, the regular menu of services, to get through the thing. And then close your ears, Commissioner. Then you put in the cost of the state operating thing in here. Now you're talking real money here, folks. Now you're talking real money in here. Because there's 2,500 people living in the state operating system costing over $2 billion. You do the math. So there's a lot of flexibility in there. And yeah, not everybody's going to survive the same way. But when we start to integrate the system, special needs population, the lack of integration, the ability to marry long-term and healthcare side for the better interest of the people starts to make some sense. When we started with CCOs, let's face it, we started with CCOs, they implemented in 18, all of us thought it's coming. We all thought it's coming. We all believed that, oh yeah, people stand up and say this is advantage care, and even we know we had to get through this. But it meant two things. It started to think about how you're going to integrate services, and it met the federal definition of conflict-free case management, right? Which is, I believe, is still the only thing that the federal government will never allow any state to put a waiver in for. That's permanent. There's never going to be a way that doesn't stay in the system, no matter what kind of payment you do. So, in a provider-led system, and by the way, it's not provider-managed. Let's have a couple of things here. The guys over here, the insurance guys, we need them to operate these things in concert with laws and regulations and things like that. But provider-led means we have the input into how that stuff gets done. And the input into this. What are some of the fears? Some of the fears are outcomes. Parents don't understand outcomes. Because, every parent says to me, my son or my daughter has profound intellectual disabilities. They're not going to reach these outcomes. Well, and you can't pay them for those kinds of outcomes. There's a difference in the medical outcome. Yes, we expect the doctors, when you go to them with diabetes, we expect them to be able to treat the diabetes and make an improvement, and we're going to pay you for that. Fair? Yeah, okay. But an outcome is measuring success, is measuring happiness, is measuring outcomes that are not as definable as that, but it is in the plan. And I think we have to separate those things out. So those are the things that are critical. Right? It's not about but we stop thinking about it as programs. We start thinking about, the continuum, but we talked about that from day one. It's a continuum. So let's keep it that way. It's a continuum of services. It's not what they'll do that, but it doesn't, you don't pay for a different thing along the way. And you pay the provider for doing it well. For providing those services and those outcomes that give people what they want in the plan. And they're all different. But they're not fantastically different. And to help people get a job. Who want them? Not everybody wants them. Not everybody's going to be able to do it. But they have to have meaningful lives. And you can pay somebody for a meaningful life. There's going to be a way to get there. It's going to take some time. If we started tomorrow, we're not going to, it wouldn't be done by the end of the year. If we started tomorrow, there's all kinds of legal and contractual, and it's going to go forever. But when we start to think about it, it's not, look at this one, staff. We'll talk from now until doomsday about the lack of staff. But in an integrated care outfit, the home care agency can be contracted with to do some of the work in a residence. or in a day drug service. They can do that. The other agency, this one, the CHOS, this one, and that one, all can be part of the neighborhood. These are the people in the neighborhood now. So that the DSPs can do the really training, the DSP, the life plan work that we're paying them to do, and not have to do everything else.
You know, I think just a comment on a couple of things you said, which I think are really important as we try to find the path forward here. You talk about outcomes, and you know, how do we measure outcomes? What are meaningful outcomes for the population that we serve? And how do we get to a system where we're paying for innovation for outcomes? And I want to just, because I know that's a concern, is how to, as a small provider, how do you develop the infrastructure? You certainly don't have money to invest in measuring outcomes and doing those things. And so in Arkansas, where there's a similar provider-led approach to coordinated care for people with developmental disabilities, 3 years into that program, they are doing quality payments, so that the first step towards incentives and innovation is not putting you at risk, right, and saying, you know, you're going to take the upside and downside if we lose money, but it's providing incentives for outcomes that are relevant to the population. So examples of that are standard measures around follow-up care after emergency room visits, right, which a coordinated system allows us to do. So can we together get an individual to a psychiatrist within a week after they've been in an emergency room for a behavioral event? So coordination measures like that. Others are measures of quality of life that you were speaking to, like, so how often are individuals getting supported employment? How often are individuals going to events or participating in activities that are outside of their residential program? So we can then sort of use those quality of life measures together to incentivize the providers who want to move forward, who are capable, who want to provide those services, to get extra money to have an incentive for that. So I think there's, you know, the outcomes does become really important, but it's a journey that starts together, right? And so it doesn't start with, to your point, diabetes measurement on day one and taking risk for that. But it's a journey we go down together.
Yeah, I mean, look, I always tell people to look at the CCOs. If you want to see what they really should be doing, look at them as the payer. Because that's really what, ultimately, that's really what the system was set up to do. The payer, of course, everybody gets going to fall right off their chair with the CCOs as payers. But it starts to have you think about the relationship differently, and I think that's something we can do now. You don't, obviously, not paying, and not everybody's going to take the same level of risk. Not everybody's going to do PM. Some people, look, there's an agency in the city. And they know JobPath. JobPath's an agency in the city. Part of the Bureau Institute of Justice. And people run the JobPath. Don used to work in Mexico. They just want to do work. They don't want to control it. They don't want to be risk adjusted. They don't want this thing or that thing. They want to be a subcontractor at their price point to do employment. What's wrong with that? And I think that's, there are a number of agencies who are going to do just that kind of thing. Some people want to do this, some people want to do that. Who do one thing terrific and don't have to worry about all these other things. And they're not the only one like that. They just happen to one of them that I know about downstate. And others of us, which are large, us, the ARCs, YI, people upstate, Access, people like that who have a multifaceted programmatic approach. Well, we're going to have to figure out how we're going to be able to take some risk. It's not risk-free, but are you risk-free now?
No. I think that's the key point.
Are we risk-free now?
Yeah.
I mean, I thought the only thing Amir said that was funny this morning when he goes, we can do, what do you call it, managed fee for service because people like their rates? I thought, what the hell is he talking about? But not anybody in this room. So you're at risk now. You provided services for not enough money. Ask the commissioner, she'll tell you. But anyway, it's like, Did everybody tell you that, Commissioner? I mean, I don't know. But the point is you're at risk now. It's not more risk. You know, the risk is different, and you'll be able to control more of it than you do now. You have no control over your bank. This is the next rate, what they call rate rationalization period's coming up, right? Who knows what? Whatever you spent in 2018, risk adjusted forward by a couple of bucks, good luck. So, I mean, that's the system we're in now. And by the way, the Feds buy into that because the Feds still, by the way, they would prefer everything be billed in 15-minute intervals, by the way. You know, they're not, this is, you know, this stuff is radical to them. They, you know, and when we tried it in 2015 and they took back $1 billion, they weren't so hot about giving us less oversight. So, so that's one of the reasons this got delayed that long. You remember that, right? But the point is, and I'm not selling it here. I'm just talking about how we have to, if we're going to do this, and I don't want to use the word, it's not inevitable, but at the same time, if we're going to think about it, this is how we have to think about it. That's
And there are opportunities. I think what you're pointing out is right now, our payment streams are not reliable, and we don't know where we're going to be. And with the way the system works right now, the rates come out well past the date they were supposed to come out, and there's a retroactive component to it, and it's a very challenging system. If we're looking at a regular system where there is not a global budget, but a known amount.
actuarially sound rates have to go to the integrated care company.
Exactly.
And that's a key.
Because you sure don't have actuarially sound rates.
Right. Go ahead.
I think that's a key point. Mark, do you want to talk about that concept?
Yeah, so I think, you know, so the concept of actuarially sound rates, give me the good topics, the exciting one. So under a managed care, coordinated care system, the state is obligated to pay the system enough money to meet the service needs of the people who are there, right? So based on past expenditures, the total amount of dollars that come into the system have to be adequate to pay changes to fee schedules. So if there's an adjustment to fee schedules, the state is obligated to pay those dollars into the system so that it moves away from a state's perspective. It becomes more predictable that the change year over year is a fairly manageable amount. From the provider's perspective, it guarantees a flow of dollars into the system rather than each year, which is something that I didn't understand as well before today, but each year sort of subject to, you know, what are the vagaries of the cost reporting, how are you going to be paid, so that it does provide longer term stability for planning.
Yeah, look, I mean, I would invest in the system that we got now. If you would invest dollars in it, you don't know what next year's rate's going to be, you don't know whether you do this, you do that. So this is, by the way, PHP has never, on the health side, has had risk-adjusted rates when they get around to it, because it's still a demonstration project. But that system, as slow as it can be, at least on the demonstration side, does work. They've never been risk adjusted on the long-term care side because it's never brought into the PNPM. Boy, hoping WC won't move on that. But anyway, it's so far. But the point is that when that's all brought in, you have a way of dealing with all of that. We have a way of moving things around. We have a way of thinking about moving some money to supported housing projects as opposed to waiting for them to the $15 million every year. So, you know, there's real ways to think about this. There's real opportunities that we can manage better. There's real risk. And that's what everybody's afraid of. It's not risk-free. I mean, some of the things now are risk-free, so I talk about it generally like you don't know what your rate is, but you live in an environment that we know. We don't like it, but we know it. We know it's going to happen. We know it's not going to happen. So there's a certain comfort in that. And this is any transition like this is going to be uncomfortable. But we have to look at it from the family and from an individual's perspective. No, it doesn't mean that they don't, families, they're only going to go to daycare 3 days a week. In the pandemic, they've been only going 3 days a week now. And I'm not suggesting that that's the way it should be. People should have meaningful activities no matter how often, how little they want. But that's how this works. And it works a lot more flexibly when it works well.
You touched a little bit on the provider uncertainty and the needing to know about metrics and where to go. And I think one of the other things we hear about are family concerns about the loss of their service. And I think Ed has said multiple times today, it's not going to go smooth. I just think if you guys could talk a little bit about how you might see that transitioning happening so we don't have major disruptions to services, as well as getting providers up to speed so that they're able to play in the game. I mean, those are, I think, two areas of concern.
Great question. I'm glad you brought that up. So I think these are areas actually that I think that you as an association and a provider community can have a lot of input into as the system transforms and as the system changes. And some of the things that are typically done to ensure that there's not disruption to individuals, disruption to providers in system change, is that existing treatment plans are honored, right? So that whatever somebody has on day one, they would have that same, the ability to have that same coordinated care, those same services until they were assessed in the new system. And so there is no sort of abrupt change from the number of hours of day have or the number of days that somebody has, things like that. It's based on an assessment, which in this system would be led by the provider. So sort of that transition of care is very stabilized. And you know, one of the themes from this morning's session was accountability, right? And accountability of a managed care organization in a coordinated system. And that comes through the way the waiver is set up, the way the contracts are set up, and again, a lot of input from you as providers. What accountability from a payer is important to you as the system is created, and how do you have that voice to make sure that there's not disruption to the individuals. And then the other question we had is about disruption to individual providers. And I think that's an area where hopefully we've learned a lot of lessons, right? We think back to the behavioral health transitions that occurred in New York, and that was before I was here, but I think one of the mistakes that was made was inadequate attention to the changes in processes for providers. And that got people in trouble. And so one of the lessons learned is that we march down that path together, that any changes are implemented slowly and together. And you know, one of the things that I would sort of put out as a relative success is in managed long-term care, where what we've learned as a payer is that our obligation is actually to go out and support individual small providers. So that part of our obligation, part of what we do, and part of the success is we have a team that provides what we very creatively call white glove service. That means going and working with individual providers on how to submit claims, what happened to claims, how do you make sure that you're tracking things, how do you make sure that authorizations are in place, and those types of things. How do you increase your revenue? What are some ideas that we have that can help build the business? So we've really learned that a key part of that transition is nothing sudden with changes to the way you are all paid, the system to use, and that there's a lot of collaboration and training and joint learning that goes on before those changes are made.
But I think
We have two things. By the way, the assessment, that's what the cash was for. That's what they built it. That's what the cash was for. It's meant, it's meant to put tiers in place for payment systems. That's why, for me, the fact that one person was assessed poorly over the course of 135,000 people, it wasn't because, when it got down to the group home, where you got to do what was it? The regional rates was 63 different combinations of need and region. I thought that was a bit much, but I think the way it was originally envisioned, I think that's 4 tiers or so, and I think you basically going to get all of that right, and then you can make some adjustments for regions. But the point is that's on the long-term care side, and then each person has a different life plan, a different payment system. But by the way, PHP has gotten tremendous accolades from the health department on health outcomes. So this stuff can work. This stuff can work if we do it right.
When I hear parents talking about their fears, usually you have two groups, right? You have the group that have services and just want to keep those services. And then you have those that don't have services and are concerned that if we make a move, suddenly they won't get services. And if you look at the protections that are in place for managed care, they're actually greater than what we have right now in fee-for-service. And it's a hard concept. You know, I hear parents over and over again in the forums that we have held, the Guidehouse forums, the 507 forums. There's a lot of misconceptions, a lot of myths out there. There may have been previous experiences, negative experiences that people had in the early years of managed care. But we really need to do a better job in educating individuals and families on what a provider-led model actually is, in that they actually have more protections in that system, more opportunity, because one of the things that we run into right now in our current system is we talk about actuarial soundness, right? And that's important to make sure that we're receiving enough funding to meet the needs of the people we serve. But we also have to move to a PMPM model because we see growth in the system. We've had over 20,000 people enter the system in the last 5 years. We're not getting a commensurate amount of funding. So what's happening is we continue to take slices and slices and slices. So in many ways, we're all frogs in the pot of boiling water, right? We don't realize that the heat is intensifying and that we're asked to do more. We're not getting inflation-adjusted rates. We're not getting PMPM for those people who are entering the system. And that's all putting a lot of pressure on an existing system that already has issues. So by moving to a different model of care, by moving to a different model of funding, because again, we have to make sure that we make very clear to people that managed care is not the end goal, right? Managed care is a means to the end. Provider-led integrated care is the means to the end. The end is people having better health outcomes, people like my son, you know, having health outcomes that, you know, that he's going to have the same life expectancy as somebody without his disability, setting aside the disability. That's not the case now. There's been plenty of journal articles, publications, studies that show that people with IDD are not living as long, they're not getting the same level of cancer care, they're not getting the same level of chronic care, and we need to improve that because, again, that is driving those additional costs and long-term supports, which at the end of the day will help pay for this, because that's the other fear that I hear from providers. Well, if we move to integrated care, it's going to take a slice out of everything. I'm going to lose 10% of my revenues because that's got to pay for the managed care. That is not the case, and that has not been the case in other systems. Again, that's one of those urban myths that's out there. We have to be very clear. There are so many inefficiencies. You have somebody spending 18 months in a hospital, that's a cost that nobody's calculating. We have people who are cycling in and out of care. The cost to you all, having to shuttle people back and forth, having to take people that have not had their chronic or their complex behavioral health care or medical care needs met, take them back into your system, that all comes at a cost. So we have to figure out, how do we envision a different system? How do we make this system work for us as opposed to against us?
Well, that's good, Nick, because I had to mention that. It's called the Kastner myth. And the Kastner myth, if you recall, was the commissioner and others standing up there and saying that the administrative overhead in managed care companies is 15%. That's all coming out of the DB system. Would anyone like to tell me what the administrative overhead for private health plan is? They've gone to 2.5. It's not coming out anywhere. And if you've had the Blue Cross guys, they got money. But the point is that there are myths and there are realities. But the overwhelming thing, which Mike wants you to know, is this. For the past decade, we have been excellent at telling government what we do not want. We don't want the Justice Center, we don't want managed care, we don't want this, we don't want that, they offer us with this and they offer us with that. You know? We don't want it done to us. We have to stick together and figure out what we want to do for us. You know, Ben Franklin said, if we don't hang together, we will surely all hang separately. And the thing for me, the thing I am most fear of, is that it goes on, they become very afraid to change the system, and they'll throw up their, government isn't good at this. They'll throw up their hands, bring in all the commercials, and then it'll be really nothing.
And you heard the beginnings of it this morning. Not that they're there, not that they're telling you it's gonna happen, but our Medicaid director and our commissioner of OPWDD certainly have in their head, they're considering options. And the options are on the integrated care path. So can we seize what control we have? Or do we just step back and let something happen to us? I think one of the things you guys have touched on here that's really good is, I think, the idea that there are a lot of myths out there. And I think if there's some other myths that you might dispel, I think when you hear about what happened in another state, there's not always a direct parallel. Yes, it had something to do with the IDP population in that state, but it wasn't constructed the same way. They didn't look at things exactly the same. So I think, I don't know if you guys have any...
In an all-comer system, that's where the DD people don't make out. Now, in any system, you can't refuse people's service in the Medicaid system, but, you know, there are plenty of Medicaid managed care plans. Like, there are a million of them out there. Everyone else but the DD people, and 35, 40,000 now of them are in it. But, you know, so I think we'll be pretty, they'll want to get a couple of plans. And the things that did not work, district, HARP, all those other things, with just a couple of plans out there, they go away. Those problems go away. We'll create others, but those ones go away.